You can find information about subscribing to this series at netrf.org/podcast, where you'll also find a bunch of helpful charts, graphs, and videos that expand on this material. If you like this show and find it helpful, please leave a review on whatever app you're using to listen to it, and we'd love to get your feedback at podcast@netrf.org. Welcome to NETWise. This is a podcast for neuroendocrine cancer patients and caregivers that presents expert information and patient perspectives. My name is Lauren Heider from the Neuroendocrine Tumor Research Foundation. For most of you who are listening to me right now, that term, neuroendocrine tumor, or NET for short, is a part of your life. You may have been recently diagnosed, or you could be a veteran expert NET patient. Maybe someone you care about has NETs. In any case, you probably have questions. What exactly is a neuroendocrine tumor? What is it doing in your body right now? And what should you be doing about it? We're going to do our best over the course of this series to help you find answers to those questions. Through conversations with some of the best experts on neuroendocrine tumors from all around the world, you'll hear about what NETs are, how they spread, and a lot about current best practices in diagnosis and treatment. You'll hear fellow NET patients share their experiences with their cancer journey. We hope this series will be your guide to being NETwise. To begin with, let's get very basic. What exactly is a tumor, and what is cancer? To understand the answer to that question, you first have to understand something about the structure of our bodies. Every part of your body, your skin, bones, hair, blood, muscles, organs, they're all made out of cells. And inside each of the tens of trillions of cells that make up your body is an identical copy of your DNA, a molecule that basically lays out the blueprint for building a you. When you get injured, the way your body repairs that injury is that the healthy cells around it divide, making copies of themselves to replace the damaged cells. This is also how we grow and make things like hair and blood. Every cell in your body has this capacity to copy itself. But every time a cell divides, there's a small chance that it won't go exactly as planned. What can result then is an unplanned cluster of cells somewhere in your body. We call this cluster a tumor. Here's Dr. George Fisher, an oncologist at Stanford University Medical Center.
So if you were to imagine that any cell that's capable of cell division all of a sudden acquired the ability to divide without control, meaning one cell becomes 2, 2 become 4, 4 become 8, 8 becomes 16, then that lack of control of cell division would allow that individual cell to become a lump. And that lump is basically what a tumor is.
So tumor can be a scary word, but many tumors really aren't such a big deal.
And this little mass or lesion or bump, however you'd like to imagine it, is composed of abnormally growing cells that might not have acquired the biological characteristics that would allow them to spread. So they just grow like a little lump, and they sit there, and they might become a mole on your skin.
And so benign, meaning non-cancerous tumors, can sometimes be uncomfortable, can sometimes even make you sick and need to be dealt with. But they are called benign because they basically stay put and mind their own business. They grow in one place and only one place. And when they're removed or destroyed, that's the end of it. Sometimes, though, we develop a tumor that has other ideas. This tumor has developed a glitch in its DNA that inspires it to not just copy itself uncontrollably, but to cause other cells it comes in contact with to do the same, causing chain reactions of uncontrolled cell growth to spread wider and wider around your body. This is called cancer. And as we all know, it is a big deal because it can often mean that these out-of-control clusters of dividing cells can grow in such a way that they prevent your organs from functioning properly. Here's Dr. Pam Kuntz, director of Stanford's Neuroendocrine Tumor Program.
Tumors develop because the cell of origin tends to divide out of control. And they become a cancer when they develop the potential to spread to other places.
Your cancer happens to have started in a kind of cell called a neuroendocrine cell. Everyone has these all over their body. They're mainly in places like your gastrointestinal tract, the lungs and airways, and the various glands all around your body. These cells make up a system that control a bunch of important bodily functions, things like heart rate, blood pressure, airflow, digestion, and lots of other things. They do this by being the meeting points between two different kinds of signaling systems that keep your body running. You see, some of the cells in your body communicate with each other by sending and receiving chemical signals. That's like hormones, which are produced by the endocrine system. Other cells, though, such as the cells in your brain, they run on an entirely different system of electrical signals, sending sparks of electricity between the different neurons. Here's Dr. David Metz, co-director of the Neuroendocrine Tumor Program at the University of Pennsylvania.
So there are cells in the body that are neurons, they're nerves, and other cells in the body that are endocrine cells that form parts of glands. And these are all essential for normal function. So those cells are all over our body, and we've got millions and millions of these kinds of cells that do regulatory functions of hormonal balancing and control, nervous functions, sensory and motor, and keeping everything together so that we are functioning normally.
And in many of these places, like in the glands that make those hormones, there's a need for a group of cells that can bridge the gap between those two kinds of signaling systems, receiving an electrical message from the nerves and turning it into a chemical message. These intermediaries are your neuroendocrine cells.
It's a translator. So it translates in a neurologic, which is really an electrical communication, to a hormonal, which is a molecular communication, where a molecule is released by a cell and goes and attaches to a different cell, and in so doing, sends a message to that cell to do something.
Just like any other kind of cell in your body, these neuroendocrine cells, they need to divide and replace themselves periodically. And when they do, there's a chance that a mistake might be made that will cause them to form a malignant tumor. And because neuroendocrine cells are everywhere in your body, neuroendocrine tumors can form just about everywhere also. About 25% of primary neuroendocrine tumors begin in the lung. About 54% begin somewhere in the gastrointestinal tract, 12% in the small intestine, 9% in the pancreas, and 29% elsewhere, including the stomach lining, appendix, and rectum. Other sites or primaries of unknown origin, they account for the remaining 21% of primaries.
So my name is Wendy Knoll. I live in Raleigh, North Carolina. I am 37 years old. So my story started a really long time ago. I was in vet school, and I was 25 years old, and I started coughing, actually while holding a dog, while working. And the veterinarian that I worked for, was kind of getting upset with me. He was like, well, stop coughing. And I was like, I can't. And he listened to my chest with his stethoscope. And he's like, good God, Wendy, you sound awful. And I was like, well, I'm not sick. Like, I don't feel sick. This is so weird. And he said, go to urgent care right now. And so I ended up going to urgent care. And the physician there sort of said the same thing, like your lungs sound awful. Let's take an X-ray. Maybe you have, and he sort of diagnosed me with walking pneumonia. From the X-ray, he said that there was a little spot there, and he wasn't quite sure what it was, and he put me on antibiotics. And then he told me, you need to go see a pulmonologist. And I did, and sort of the story continued there that the pulmonologist said, you're 25. I don't think that spot is anything. It's probably a lymph node. Let's go ahead and test you to see maybe you have asthma. And so I had a whole bunch of breathing tests, and he put me on steroids and inhalers, and for months, I would use the inhaler and I wouldn't get better, and so I was getting really frustrated. And so I got really upset, and I went back to him and I said, with all due respect, I'd like to get a CAT scan. And, I'm really scared about this spot in my lung. And he was like, Wendy, you're really young. This is not anything to worry about. So then he sort of, not angrily, but just wrote the script to get the CAT scan. And I went and had the CAT scan done, and literally I just walked out the door from getting the CAT scan done, and he called me and he said, I need to see you in my office right away. And I knew it. I knew that it just wasn't normal. And at that point, they had told me that it was a carcinoid, so I went crazy looking for information.
One confusing term you may have heard is carcinoid. This is a term that dates back more than 100 years and refers to the fact that most NETs are very different from other kinds of cancer. The main difference is that some NETs grow very, very slowly. So slowly that when they were originally discovered, it was thought that they might not actually be cancer at all. So this term, carcinoid, which literally means cancer-like, was invented to describe them. It's a problematic term, though, because as our understanding of NETs has increased, we've come to realize that they do behave like other cancers. They just do it at a different pace. Here's Dr. Eric Nakakura, a surgeon at the University of California, San Francisco.
Neuroendocrine tumors in general, you often hear the description as being cancers in slow motion, because even neuroendocrine tumors that have spread to other parts of the body, such as the liver, can be indolent and not grow for months or even years. And so this is in contrast to many other types of cancers that have spread to the liver, where week by week, month by month, there's clear, gradual growth.
And partially because of this carcinoid label, physicians, until very recently, tended to misunderstand just how dangerous NETs actually are.
Neuroendocrine tumors, even as recently as 10 to 15 years ago, were actually all classified as being benign. And I think that pathologists for a long, long time called these benign, and thus so did doctors taking care of these patients. And so then patients had this belief that these cancers would never come back. And we now know that these, in fact, are cancers, and they can grow and spread, and therefore they need to be treated as such. They need to be treated like cancers, and therefore patients need to have appropriate surgeries and treatments, etc.
In my mind, I think neuroendocrine tumors in general are all malignant. They all have malignant potential. The number we usually quote is 60 to 90%. I think of them all as having potential for malignancy if you leave them alone long enough.
And what does that word malignancy mean exactly? Well, your cancer is named for its primary site, the place where the very first tumor appeared. But that location is just the beginning. Like all cancers, NETs have the potential to spread elsewhere. That tendency to spread is called malignancy. And the new tumors that form are called metastases, or metastatic tumors. The first place that most NETs spread is into the lymph nodes that are nearest to the primary site. Lymph nodes are a kind of gland. They work as filters for harmful substances in the body. They carry oxygen and other nutrients to cells and carry away waste products that flow out of the cells. It's almost like the plumbing system in your house. Here's Dr. Dan Halprin, an oncologist at MD Anderson Cancer Center in Houston.
So a lymph node is basically a docking station of immune surveillance as fluid tracks back to the circulation from really any end organ. So as blood pumps into any organ, so the fluid pressures basically push some of the water out into this space, the lymphatics, and then that will drain back through these little docking stations where we find all of these various immune cells.
This lymphatic system is the way many cancers, including NETs, travel from one place to another.
And the presence of cancer in lymph nodes where the cells is a way of saying that the cancer cells have made their way into that lymphatic network and are moving and surviving within that lymphatic network. And so the lymph node, the presence of the cancer in the lymph node is an indicator that that cancer has the ability to travel.
The more a cancer spreads, the more serious it is. And managing and treating the spread, it generally becomes more important than dealing with the primary tumor.
We typically think of cancer in terms of what we call a TNM hierarchy, or tumor node metastasis hierarchy, and this is how we stage the cancers. And we consider them sort of in order of importance. So the tumor is the initial site, and then if it moves to the lymph nodes, that's more important than what's going on at the local tumor. And similarly, if it moves and metastasizes, and we're dealing with disease in the liver or the bone or somewhere else, that really takes precedence over what's going on in the nodes or the primary tumor. So particularly from a, say, prognostic standpoint.
The distance cancer spread from its primary location is referred to as the cancer stage.
Stage refers to where in your body is the cancer. So let's use as an example a pancreatic neuroendocrine tumor. So that just by definition would mean that it started in the pancreas, and that could be a stage 1, 2, or 3, depending on where it is in the pancreas and whether or not there are lymph nodes involved. Once it spreads far outside the pancreas, so for example to the liver or to the lungs, that by definition would be a stage 4. There are only 4 stages, and so 4 is the most advanced stage, and then by definition that also means that it's metastatic or has spread.
NETs metastasize in a way that can be different from almost all other cancers. The metastases of NETs usually grow much bigger and faster than the primary tumor. Here's Dr. Xavier Koitgen, a surgical oncologist from the University of Chicago Medical Center and director of their neuroendocrine tumor program.
Classic cancers usually have a larger primary tumor and then a smaller amount of lymph node metastases or distant metastases. So neuroendocrine tumors, it's a little different. Often we see very small primaries, especially for small bowel, but a really significant amount of lymph node metastases and even a higher burden of distant metastases.
Neuroendocrine tumors are upside down tumors in which the primary is tiny. The lymph nodes are a little bit bigger, but the spread to the liver and the bones and everywhere else is formidable.
Metastases happen in places that pieces of the primary tumor can find a way to get to. For example, with NET primaries in the small intestine and pancreas, metastases can occur in the abdominal cavity that surrounds these organs.
Neuroendocrine tumors that arise in the pancreas and in the gut can literally just go through the wall of the colon or the appendix or fall off of the pancreas and land in the fat in the abdomen and find a place to grow there. We call that intraperitoneal seeding. It's really the simplest kind of spread, because if you imagine a tumor that makes it through the wall of whatever organ it's in, and then seeds from that tumor, individual cells, can literally fall off and just land anywhere in the abdomen. If they survive the fall and land in a place that's fertile ground, and if they can then recruit a blood supply to feed them, then that individual seed can become a tumor of itself.
But the most usual way for these seed cells to travel is the way most things travel around the body, through the bloodstream. Because of this, the very most common site for small intestine and pancreas NETs to metastasize is your liver, because that's the first place blood from the small intestines and pancreas goes. Here's Dr. Ed Wolin, the director of the Center for Carcinoid and Neuroendocrine Tumors at Mount Sinai in New York.
Neuroendocrine tumors that start in the pancreas and intestine preferentially go to the liver when they metastasize. The tumor cells go into the blood supply that leaves the pancreas and leaves the intestine, which is called the portal vein. And that vein goes directly to the liver to filter the blood. So it's a bypass tract that takes the tumor to the liver. So the liver gets a big dump of cancer cells before the rest of the body. And that's why you see people with neuroendocrine cancers sometimes that have 20, 30, 40 liver metastases and don't have much else in their whole body.
And because of the strange upside-down nature of NETs, the metastases are generally much bigger than the primary tumor that seeded them. And it's very often these liver metastases, not the primary tumors, that cause the biggest health problems.
So the number one cause of a decreased lifespan in neuroendocrine tumor patients are liver metastases that become so overwhelming that the patient gets into liver failure.
Other kinds of NETs, like lung NETs, for example, they metastasize differently because the blood flow is different.
Lung neuroendocrine tumors, when they metastasize, don't go directly to liver the same way that intestinal and pancreatic ones do. The cancer cells go into the bloodstream, they go over the body, and you don't necessarily find a lot of cancer in the liver if you don't have a lot of cancer everywhere else.
So this was 2005. I had my 3/4 of my right lung removed. So after that, I went on to live my life. I got checked every 3 months and every 6 months and every year via CAT scan of my chest. And everything came out clean. I got married to a wonderful, handsome man. I had a beautiful daughter 8 years ago. Then I had another beautiful daughter 2.5 years ago. And there was a point where it was my 7-year checkup. And I got a new oncologist. And he said, you know what, Wendy, it's been 7 years. This cancer is not going to come back. He's like, we don't even need to do these CAT scans on you anymore. Probably, let's do it every 5 years. And I was like, whoa, that's awesome, but so scary. And I'm not comfortable with every 5 years. And he's like, okay, how about every 3 years? And I said, okay, let's do 3. 3 years went by, and I went and had my CAT scan done. He said, Wendy, I see some changes, and there's something in your liver. And also some lymph nodes are larger. So let's get an MRI. And they fit me in that day. And then I called the doctor, and he called me back that night. And he said, you have tumors all over your liver. There's also some in your pelvis, in your spine, and all throughout your lymph nodes. And then the biopsy came back, and it was determined that it was the same cancer as my original tumor. But now they were calling it neuroendocrine tumor.
Wherever a primary NET appears and wherever it metastasizes to, NETs can be difficult to diagnose and very often misdiagnosed. This is also closely related to their bizarre upside-down nature. Because the primary tumors can be much smaller than the eventual distant metastases, NETs are often not discovered until after they've spread, which might be many years after they first began.
The problem with neuroendocrine cells is that we don't really see the benign cells. We don't have a way of detecting them, and oftentimes when they've grown, they've already spread by the time we can first diagnose them. So they tend to be diagnosed at a point where most patients already have spread of the disease.
Often, NETs aren't discovered in the body until they begin to cause symptoms. One way they do this has to do with the fact that some NETs are what we call functional tumors. This means that they have the ability, like healthy neuroendocrine cells, to produce hormones. These extra, unwanted hormones can cause a whole range of different problems in your body. These functional NETs, they can be referred to by the name of the hormone they produce. So a NET that produces the hormone gastrin, for example, it can be called a gastrinoma. Or the one that produces glucagon, that's called a glucagonoma.
I'm going back to the terminology neuroendocrine. They have the word endocrine because they share these endocrine features of secreting hormones. One of the classic examples of that for small intestine NETs is that the tumor can secrete a hormone called serotonin. And serotonin can cause things like flushing of the face, which is sort of a periodic redness of the face, or really watery diarrhea.
That particular set of hormonal symptoms is called Carcinoid Syndrome. and it can be typical in NETs that have metastasized to the liver. We'll talk about functional NETs and the various syndromes they cause in depth later in this series. But for now, there's a big problem here in terms of diagnosis. Those symptoms, diarrhea and redness of the face, they could be caused by other things that are more common than a neuroendocrine tumor. This is true for most of the symptoms with NETs: stomach pain, jaundice, persistent coughing. All of them could be caused by something that most doctors would see in a patient every day, rather than an uncommon condition like NETs, which they might never have seen before in their entire career.
To be honest, neuroendocrine tumor is a rare cause of diarrhea. There are far more common causes of diarrhea. And so, if you go to see your internist and you say, geez, I have diarrhea, and he'll say, well, how many times a day? And you say 3 or 4 times a day, and you'll say, well, go ahead and take some Imodium. Or they'll do a stool test to see whether you have an infection. Or they might even do a colonoscopy and look for inflammation in the bowel and decide that you don't have any inflammation and therefore you're okay and just take these medications.
So it's not often that you make a diagnosis of gastronoma, but you'll see a whole lot of ulcers. It's not often that you make the diagnosis of carcinoid syndrome, but you'll see a whole lot of middle-aged women who are menopausal and flashing and have diarrhea. So the patient gets labeled as having irritable bowel syndrome and maybe being perimenopausal when they really are showing the carcinoid syndrome. Or the patient gets labeled as having a typical ulcer and heartburn and reflux disease when they've really got Zollinger-Ellison syndrome and a gastronoma.
1 in 2 NET patients is initially misdiagnosed. On average, people have symptoms for 5 years before learning that they have a neuroendocrine tumor. When it takes that long to obtain an accurate diagnosis, cancer can spread. More than half of NETs metastasize before they're diagnosed.
My name is Marilyn Klein, and I'm a neuroendocrine patient, cancer patient. And I was diagnosed in June 2017. I'm PNET, pancreatic NET in the tail with METs to the liver. That is my official diagnosis. My story is not unsimilar to many others I've heard where I had symptoms of not feeling correct for a number of years. But for me, it actually started Labor Day 2016, where I had an internal bleed and ended up in hospital with something called Doulafroy lesions, which I'd never heard of. I had to look it up, and they went in and clipped it and shut it, and then they said, oh, you're fine, you're healthy, nothing to worry about. And I didn't believe that. And so I asked for a GI consult, which I got, who also told me I was fine, healthy, nothing to worry about. My questions, of course, were, well, should I change my diet? Should I be exercising more? Should I have a colonoscopy more frequently? I had all these questions. But this GI doctor said, no, you're perfectly healthy. And I did have a pain on my left side, which, now I figure was the primary tumor in the pancreas. But again, this is a story that I hear a lot from other NET patients, is that they would go to doctor after doctor after doctor, and everybody would say, well, you look fine. You look healthy. You look great. Nothing wrong with you, until you get, the CT scan or the PET scan or both, and they show up with the metastases. The first diagnosis from my GI doctor was, I'm not happy. Let me see if I can get this verbiage, if I remember this verbiage right. I'm not happy with the way the scan looks. I'm going to get another one. So I had another test. The first was an ultrasound. The second was a CT scan. And after the CT scan, he said, well, it looks like you've got lymphoma, but I want to verify. So then I had a PET scan. And then he said, oh, I'm really sorry, Marilyn, you actually have liver cancer. And that's the point I said, doctor, I really think I need to see an oncologist. I would like an oncologist consult, and that needs to happen in the next 24 hours. And he said, oh, I'm not sure. I said, it needs to happen in the next 24 hours. And he got it. I mean, I called about 5 times, but I got to an oncologist in the next 24 hours. And that's who got me the biopsy, got me the right PET scan, and got me the correct diagnosis.
Another way a NET might cause symptoms that allow it to be diagnosed is through what's called mass effect, meaning that the size of the tumors get to the point where they're physically blocking something.
So the prototypical small intestinal neuroendocrine tumor is a neuroendocrine tumor of the ileum, so that part of the small intestine just before the large intestine. And what happens with these tumors is they are frequently diagnosed very late, only when patients start having symptoms such as abdominal pain, or they can actually have blockage or obstruction of the intestine where they're vomiting and unable to eat. And what happens is that the tumor starts in the wall of the intestine, spreads to the lymph nodes in the region, and causes a scarring reaction, what we call a mesenteric mass. So it's actually a ball of tissue that's very, very hard. And that mesenteric mass then kind of kinks and buckles the intestine, causing a blockage. And that it's the development of this blockage that leads to abdominal pain, often when they eat large meals or food that's hard to break down into small pieces. And ultimately, when they get blocked, that's when they end up in the hospital, when they're vomiting.
That's just one way a mass effect might occur. Anywhere that a blockage might get in the way of some important bodily function can be a place that a NET may cause symptoms. These could range from a tumor in the liver blocking a bile duct and thereby causing jaundice, to a tumor in a lung blocking a bronchial tube and causing persistent coughing. As we heard, the liver is a hotspot for NET metastases. And ironically, the natural resiliency of your liver can often work against the discovery of metastatic NETs.
Another curious thing about neuroendocrine tumors is that you can sometimes see large lumps in the liver, sometimes the size of several softballs, occupying valuable real estate in the liver and crowding out normal liver. What then can happen is the normal liver, which has the ability to grow, to replenish itself, can get bigger and bigger and bigger as the tumors occupy more and more space, and the person can have a lot of disease in the liver and still have completely normal liver function and feel perfectly well.
That may seem unbelievable, that a tumor could grow to the size of a softball or even bigger before someone notices that it's there. But the fact is, no one is going to do the things required to discover a tumor unless they have some reason to look for it. And with many NETs, the noticeable symptoms that would cause a doctor to look for a tumor, they don't appear for a long time, or they don't appear at all. Because of these challenges, one of the most common ways that NETs are diagnosed is by accident. Imaging technology platforms like CT scans and MRIs, they're being used more and more routinely. And because of that, it's getting more and more frequent for a NET to be picked up on a scan that was being done for an entirely different reason. Here's Dr. Thor Halfdanarson, an oncologist at the Mayo Clinic in Minnesota.
So these are patients who come in, have a scan for a kidney stone, and we find the pancreatic neuroendocrine tumor, which might have been there for years and could have been there for another 10 years without anyone knowing. But just because we were doing so many more scans, we're picking up so many more tumors.
So we get so many scans now, CT scans in emergency rooms for people who ate a bad taco, come in with a bellyache, and they get a scan. And they may see that there's a spot on the pancreas, or they may see that there's a spot in the liver or multiple spots in the liver. And they get a biopsy, and then they're told that they have a neuroendocrine tumor that has spread. It's always a scary thing, and to imagine that all of a sudden you're diagnosed with a terrible disease when you feel pretty well must be devastating and confusing.
It's not only scary and confusing to have been misdiagnosed or accidentally diagnosed with something like cancer, it's also really frustrating. How could my doctors miss something so important? A popular metaphor that's often taught in medical school is when you hear hoofbeats, you should think horses, not zebras. And this makes sense, generally speaking. As a primary care doctor, you're orders of magnitude more likely to be dealing with something other than an uncommon cancer when someone comes in complaining of diarrhea, stomach cramps, a persistent cough, or flushing. But the problem, of course, is that zebras do exist. And NET patient, you are a zebra. The good news is that there are more fellow zebras out there than you might think. It's an interesting thing that because of the slow motion pace of some NETs, while a new diagnosis of NETs is much less common than many other kinds of cancer, there are a lot of people living with NETs, more even than with much more well-known diseases.
They're actually common in terms of how many patients are out there with neuroendocrine tumors. We don't have a ton of new diagnoses per year, but just because patients with neuroendocrine tumors live long compared to many other cancers, the number of patients with neuroendocrine tumors at any given time is fairly high.
So there are hundreds of thousands of people walking around the United States right now with neuroendocrine tumors.
That's more than the number of Americans with stomach cancer plus pancreas cancer added together, which is phenomenal because everybody knows about pancreas cancer and stomach cancer, but they don't think about neuroendocrine cancer.
So it's actually, while not that many people will get diagnosed with it, it's not as uncommon to meet someone who's living with a neuroendocrine tumor as you might think.
Because of those numbers, more and more people are becoming aware of this disease, and more researchers are joining the fight against it. This means that there are actually quite a few treatment options that are available for NET patients, from surgery to medicine to nuclear medicine. So NET patients are surviving and even thriving for longer than ever. In the next episode, we're going to talk about how your doctors learn all that they can about your particular tumor and how that information will determine a course of treatment. Then in the following episodes, we'll look at all of the most popular treatment options currently used for NETs. And we'll give you as much information as we can about how they're best used and why and when, and what you can expect if you receive them. So stay tuned. All of that and more for living your best life, even while you're living with NETs. Thank you, listener, for tuning in to NETWise. My name is Laren Heider. I'm the Director of Education and Outreach for the Neuroendocrine Tumor Research Foundation. I executive produced and co-wrote this series. It was produced and co-written by David Hoffman of Citizen Race Car. This episode was made possible by the generous support of Advanced Accelerator Applications, a Novartis company, Lexicon Pharmaceuticals, and the Vincent E. Taylor Patient Education Fund. Special thanks to everyone we interviewed for this episode. We are grateful for your expertise. This is a production of the NET Research Foundation. We're committed to improving the lives of patients, families, and caregivers affected by neuroendocrine cancer. We fund research to discover cures and more effective treatments, and we provide information and educational resources. Please visit us at netrf.org.
This podcast is not intended as and shall not be relied upon as medical advice. The Neuroendocrine Tumor Research Foundation encourages all users to discuss any information found here with their oncologist, physician, and/or appropriate qualified health professional. Listening to this podcast does not constitute a patient-physician relationship. The Neuroendocrine Tumor Research Foundation does not represent that any information provided here should supplant the reasoned, informed advice of a patient's oncologist, physician, or appropriate qualified health professional.